Good afternoon. Thank you for the introduction. My name is Ioana Creanga-Murariu, and my PhD, almost, and my PhD is about cannabinoids in the landscape of cancer. I'm an oncology resident and a bilateral PhD student at Grigore Tepopa Medicine and Pharmacy University in Iași and here at Semmelweis University. My vision is an improved quality of life for cancer patients, and the mission is to decrease disease burden in cancer patients. For this year, I have three specific goals. The first is to investigate the safety and efficacy of cannabinoids in cancer patients. As you know, cancer incidence is increasing, however, the mortality is decreasing, so quality of life is as important as an efficient therapy. The most prevalent symptoms for cancer burden are fatigue, pain, and lack of appetite. Almost 30% of cancer patients admit using cannabinoids, either physician-prescribed or illicitly procured for the palliation of their symptoms. Although popular, cannabinoids raise some issues regarding the proper therapy indication and safety. So we want to investigate whether cannabinoids are safe and more efficient by comparison to standard of care or placebo for the palliation of cancer-associated symptoms. For that, we are going to investigate cancer patients that are administered cannabinoids compared to standard of care or placebo, and we will assess the efficacy for pain, nausea and vomiting, cachexia, mental alterations, quality of life, the tolerability and safety. Our clinical implication is that we could have a new palliative drug and improve quality of life. We conducted a systematic search in 3 databases, and in the end, we ended up with 98 eligible full-text articles. In the right part of the slide, you can see our finished outcomes. I will choose to present you some very interesting results. The first is the efficacy for pain, which was measured in advanced cancer patients that were experiencing this despite their usual opioid treatment. Pain was measured using the numerical rating scale with 0 meaning no symptom and 10 meaning the worst symptom intensity. Here you can see results from randomized controlled trials where patients received some drugs based on THC and CBD, which are the most known active molecules within the cannabinoid. We can see a tendency towards analgesia, however, it is not clinically relevant. The patients had a drop in their pain intensity with only 0.25 on this 0 to 10 scale. The second outcome is appetite, again for appetite improvement, again for advanced cancer patients. Here the outcome was measured using the numerical rating scale. However, 0 meant no appetite and 10 meant best appetite. These patients also received THC and CBD-based drugs. Here we could see an improvement in their appetite with 1.2 on this 0 to 10 scale. However, it is not mathematically significant. Nausea or complete response to nausea after emetic chemotherapy, where patients received THC-only based drugs, we could see that the odds for complete response was 1.6 in favor of the intervention, but again, not mathematically significant. We analyze other outcomes, such as daily worst pain, constipation, insomnia, daily maintenance, opioid use, quality of life, and depression, but we could not find any improvement nor worsen in their outcome. Interesting, we analyzed the side effects. The most important results were for psychiatric side effects, which included hallucinations, delusion, paranoia, psychosis, nightmares, and anxiety and mood swings. Patients that were administered THC-based drugs had 10 times the odds of developing such a side effect, while patients that received THC and CBD drugs had the odds of 2.6. Here you can see a list of all the side effects of cannabinoids. Only asthenia and gastrointestinal side effects were statistically significant. One limitation of our study was that we could not group the side effects based on their grading. However, the articles provided us information about the number of the patients that stopped their treatment due to increased toxicity. THC users had 3 times the odds of stopping their treatment. THC and CBD users had the odds of 1.3. Our study has strengths because we assessed multiple outcomes. We conducted a comprehensive analysis of every type of cannabinoid with rigorous methodology. But limitations come from the inclusion of interventional and observational studies, the increased heterogeneity of the intervention and population, and not forget that these were self-reported soft outcomes. So to conclude, cannabinoids have considerable side effects with minimum benefits for the palliation of cancer-associated symptoms. The implication for practice is that we should not prescribe cannabinoids for pain, insomnia, or constipation due to lack of effect. However, the implication for research is that we should continue the research for their benefits for nausea and appetite, because we saw a clinically relevant improvement, but not statistically significant yet. And we should investigate more the mechanism of psychiatric side effects dependent on the concentration and the dosage of the THC. Here you can see the status of my manuscript. The second project is investigating the antitumor activity of cannabinoids in preclinical models. As cancer treatments are among the highest in the healthcare system, alternative treatment options are always developing, and sometimes repurposing drugs with other indication is a cheaper strategy. The antitumor effects of cannabinoids were demonstrated in preclinical studies and investigated in various cancer models. So our question is to see whether cannabinoids have antitumor activity compared to controls in preclinical tumor models. For that, we are going to investigate in vitro and in vivo tumor models that were administered cannabinoids with or without chemotherapy, compare them to controls, and assess the antitumor effect, which means the decrease in tumor cells and volume. The research implication is that we will have a new anti-cancer drug and decrease in cancer-associated mortality. Again, we conducted a systematic search, and we ended up with 230 eligible full-text articles. We finalized the data extraction and now are doing the risk of bias. And finally, my third project is investigating the profile of cannabinoids use among cancer patients. As you know, cannabinoids are gaining popularity among cancer patients. However, only dronabinol and nabilon are FDA approved. The medical cannabis is still not FDA approved, keeping in mind that 40% of cancer patients admit using cannabinoids with the legal medical cannabis global market size of more than $13 billion. Our aim is to investigate the profile of cannabinoid use among cancer patients. For that, we are going to assess the characteristics of the patients, and we are going to analyze their age, employment, education, cancer type, stage, comorbidities, and prescriptor, and the particularities of cannabinoid administration, which means their indication, the type of cannabinoid, the route of administration, and form of administration. We hypothesize that cannabinoid use is dependent on the demographics. The clinical implication is that we can prescribe drugs according to the patient's preference and design future studies which support the patient's need. Here you can see 4 articles with the same answer to the question framework, which ensures that our project is feasible. No other meta-analysis on the topic, which means that the whole project is feasible. So in summary, I have 3 specific goals. All of them are related to cannabinoids. The first is their ability and their safety and efficacy for symptom control. The second is about their anti-tumor activity. And the third is the profile of cannabinoid use among cancer patients. Thank you, and do not forget, the harder you work, the more luck you seem to have.
Thank you very much for this very relevant lecture. Is there any question?
Hi, thank you for your presentation. So I've got a question. I saw you mentioned illicit cannabis as well. Do you think it should be part of the exclusion criteria when it comes to illicit cannabinoids? Because I think standardized medical cannabis is obviously going to be a lot more beneficial to a patient. What's your opinion? Do you think there should be a piece of research that could, ethically compare the use of illicit cannabis and medical cannabis?
Well, I don't entirely agree with you. I think as clinicians should be aware of the potential harms and benefit of cannabinoids regardless of their legal or unlegal status, because the reality is that cancer patients will always try to seek alternative treatment, and we as doctors need to know how to manage the side effects. It could be an interesting idea for the future because we cannot really know what's inside the cannabis plant that was illicitly procured, because within a plant we can find 100 molecules and each and one of them has a lot of effects. This could be really interesting in the future. However, for this moment we could not divide our analysis between illicitly procured and standardized medication.
Could you mention in your second project, could you mention the preclinical tumor models, or what types of models?
Well, the majority of the tumor models that cannabinoid research was conducted were glioblastoma. These were the most articles that were published. The second is breast cancer, and the third is melanoma. However, I could find scarcely divided articles for sarcoma, prostate cancer, leukemia. But in the future, we could meta-analyze only the first three that I mentioned.
What is the preclinical means in these cancers?
The preclinical?
Yeah, you mentioned it's a preclinical tumor model.
Yeah, we will going to analyze the tumor cell models and the animal tumor models separately.
And how are you planning to measure the anti-tumor activity of the cannabinoids?
For the cellular studies, we are going to measure the decrease in tumor cell number. We chose articles that were measuring this using the same laboratory assay, which gives us information about the percentage of the viable cells. For the murine models, we are going to analyze the percentage in the tumor reduction. In the majority of the articles, they used calipers as a ruler to measure the tumors, which means that we can compare between the studies.
And do you suspect there is any anti-cancer activity of the cannabis itself?
We suspect heterogeneity. When I say heterogeneity, I speak about anti-tumor and paradoxically pro-tumor activity, because this effect is highly dependent on the type of the cannabinoid, the dosage, and the form of administration. And I could find results in both aspects.
Very interesting. And do you know which country is it most frequently prescribed for cancer patients?
I don't know for sure which is most frequently prescribed, but I know there are established headquarters for cannabinoid research, for patient cannabinoid research in Australia, Canada, and Israel. But I believe that other countries where cannabinoid is legal have higher numbers of patients that receive this medication. Not forget Germany, that in this year they legalized also recreational cannabinoid use.